Our speaker is Dr. Sunny Dzik. He's the co-director of Blood Transfusion Service at the Department of Pathology and Medicine at Massachusetts General Hospital and Harvard Medical School in Boston, Massachusetts. Dr. Dzik will be talking about transfusion in sub-Saharan Africa, past, present, and future.
I'm going to begin with some important data. This slide shows you the projected world population projected by the World Health Organization for the next half century. Time is on the x-axis, and the number of people is shown in billions on the y-axis. What I want you to note is the area on top in the red sector, which is the projected population in Africa. WHO anticipates that the largest increase in human beings will occur right here in Africa. And this growth in population will demand an increased growth in healthcare services, which in turn will demand an increased growth in blood transfusion therapy. So it is completely fitting that we join together in these series of lectures to prepare for that future, because the future is inevitable and will require a large amount of transfusion support. So I'd like to give remarks first with the past, then speak about the present, and then speak to the future of where we may be going in our profession. This next slide shows you the record of what was probably the very first transfusion that was conducted in Africa. It was done in 1921. It was a time when World War I was active, and some of that war had spread down to the African continent. And a British soldier who fell ill, probably with malaria, was treated in a last-ditch effort with a blood transfusion. You can divide the transfusion history in Africa into a series of segments shown at the bottom of the slide, which include the area between the wars, then the time leading up to independence, then a period of decline and disarray that accompanied HIV and civil strife, and then finally a bright and hopeful period of recovery that brings us up to the present moment. This next slide shows some early footholds between World War I and World War II. It notes some of the key events which occurred between the wars, and I'd note at the very top line that in 1931, that the first blood grouping was done actually right here in Kampala in Uganda. Several other key events followed throughout the 1930s and early 40s, and you can see that there's a gradual and steady increase in the number of records of blood donors that occurred during that time. We can actually track the use of blood and the growth of blood services by looking at the number of blood donors which were drawn during each of the years of the 20th century. And the next few slides will show you that data as it pertains to Uganda. For example, here we see the early years of the 20th century in the period from 1950 to 1975. On the y-axis are the number of blood donations given annually. And I'm going to show you just the data from Uganda because there is good data from Uganda, and after all, Uganda is our host for this conference. And as you can see, in the period that following in the 1950s and then leading up to independence and after independence, there was a gradual and consistent and steady growth in blood activities, such that in 1975, it's actually about 30,000 donations in 1975, a rather robust activity of the blood services in Uganda. But then a terrible thing happened, and it was a very difficult decade here. And the decade of the 1980s was dreadful. HIV came to be, as we all know. People became very fearful of donations, very fearful of transfusions. There was also, as you know better than I, very serious civil strife in the country, mismanagement by the government, and all of that hardship is reflected in the absolute decline in the 1980s, such that by 1984, 1985, the system which had done so well in the past had completely disassembled and deteriorated. And I just want to read to you a kind of a sad statement of the situation at the Nakasira Blood Center, not too far from here, in 1984. So look at this. After years of civil strife, the Uganda service had run out of blood-taking sets. Personnel attached old needles to tubing and put these into an autoclave which didn't really have any temperature control. Bottles filled with blood were obtained only by exchange for an empty bottle. You had to bring an old bottle in order to get a bottle of blood. There had been no running water for 10 years, no telephone for 7 years. All of the blood responsibility essentially shifted back to the hospitals. And this was not good because the hospitals were not, of course, doing any HIV testing. There was no hepatitis testing, no viral testing. And so everything kind of fell apart. Despite all that, there was then a period of really amazing recovery. Look at this. This is astounding. A dramatic period for this hitting bottom in 1984. This takes us in the last 15 years of the century to a tremendous growth in and recovery in blood services, such that by the year 2000, the Uganda Blood Center was collecting nearly 90,000 units of blood. What's even more striking, not on this graphic, is so this ends at 2000, we're at 90,000 units. If we were to take this just another 10 years or so to the present, it's at 200,000 units. It doubles. And you're going to hear from our next speaker part of that success story. So this is, you should be enormously proud of this, given where you started at zero. And this is a great achievement. Despite that huge success, projections indicate that still the supply in sub-Saharan Africa is way behind the demand. It's seriously behind the demand, and that's shown on this slide. So what you see here on the x-axis is number of units which are needed, and this is in log distribution, so these are powers of 10. This, if you can't read it in the back, this is 10,000, 100,000, 1 million. And the red line on the bottom is how much blood is collected. So this is not Uganda, this is all of sub-Saharan Africa. About 6 million units annually are collected. But this is the need in blue, the need for patients with sickle cell disease, trauma, surgery, obstetric hemorrhage, all the things that you'll be hearing about in the next 2 days. And the sum of this need is about 13 million. So the collections are 6 million, the demand is 13 million throughout Africa. And that difference is a kind of a window on this future that I was talking about, because as population increases and healthcare increases, demand is going to even continue to increase. And so there is a critical need for transfusion professionals to take us into that future. So that's my brief summary of the history. And now I want to say a word or two about the present situation. Now, it would be impossible to give a talk on transfusion or really anything related to healthcare at this moment in time unless one mentioned Ebola. So this is a scanning electron micrograph of the Ebola virus. And if you haven't seen it, you know, the Ebola virus is not like many viruses are just a round, looks like a little sphere. And this, of course, does not look like that. It has lots of kind of tentacles and arms, and it seems to want to stick to things. And I'm sure that contributes to its high level of contagion. The Ebola outbreak, which the world is observing, and we observe it sadly, and note with solemnity the tremendous destruction that is occurring in West Africa and the effort that West Africa is making to really adjust to this terrible virus. It has been devastating, as you know. Currently estimated that 13,000 people have been infected, well over 5,000 people dying, and dying sadly, dying miserably. This is not a disease that takes you lightly. It's a suffering disease. People like you, healthcare workers, have been heroes, I think, on the front line. And many healthcare workers in West Africa, of course, have perished trying to help patients. And so I think at a moment in any conference that has to do with medicine, I think one should pause a moment to think about the sadness of Ebola, to remember the lives that were lost, to hope that they're at peace now, and that some peace is brought to the surviving relatives, because this is a terrible sadness. Blood transfusion has been a part of it, you might be surprised to know. And in fact, the World Health Organization has endorsed the use of blood transfusions to combat Ebola. although, as you can see from the headline, despite skepticism. And I want to explore that with you in the next couple slides. A very important journal, Nature, which publishes only the really best stuff, noticed that blood transfusion should be a priority treatment for Ebola. And this quickly sparked, as you can imagine, a black market of survivors' blood being sold to treat Ebola. Now, the story here, it's not about the blood the way you think of blood. When I say blood to you, you're thinking red blood cells. But this is about the plasma. So the idea is that if I get the infection and I survive, I've now developed some immunity. So I have some antibodies in my plasma that could fight the virus. I become somewhat immune. So the concept was to take my blood and give it to a sick person in order that they would receive the antibodies, the immune antibodies, as a source of treatment. So when you hear about blood transfusions as a treatment for Ebola, we're not talking red cells. We're talking antibodies that are in the plasma. So we call it convalescent plasma because the person has survived. Why are we doing this? And it stems from this data from the DRC in a 1995 outbreak in Kikwik. And there were 300 cases or so of Ebola in 1995 in the DRC. And 5 people who survived, just 5 people who served as blood donors, and they gave just like half unit or 1 unit transfusions to 8 recipients. The recipients were very sick when they got these transfusions, and remarkably, some of them survived. And they looked at the data at the end, and they said, overall, we had 316 infected people, and 80% of those people died. But among the 8 people, a few people, among the 8 people who were transfused, the mortality was only 12%. Well, that sounds pretty good. 80% death rate if you're not transfused, only a 12% death rate if you are transfused. And so this led some ideas that maybe this would be an effective therapy. However, the skeptics said, well, there was really no controls. This was just an experience. This was not an experiment. And they tried to repeat it in a monkey model, and it didn't work. And they also noticed that these transfusions were given rather late in the course of illness, so that maybe the patients would have recovered anyway. So let me show you let's get right to the details of the data, and that's shown on this slide. So this is data I fished out from the original report in 1995 in the DRC. And I'm just showing you the results of 5 patients across the top. And there's 2 columns for each patient. In one listed AG here, this is the antigen. This is basically the Ebola virus. And this is, next to it is the antibody. And the little red drops are where the transfusions were given. At first glance, it kind of looks pretty good. Let's look at this guy in the middle, huh? He's got virus, no antibody, virus, no antibody. And then he gets his blood, and now it's negative, the virus is negative, and the antibody is positive. So it looks like he kind of cleared his virus and developed a positive antibody just at the time of the transfusion. That's how it kind of looks. But if you look very carefully, it's a bit different than that. So patients 1 and 2, these first 2 columns, as you can see, between the time of the transfusion and the time of the positive antibody, there's quite a few empty days here. So you can't be sure that the transfusion caused the antibody. Maybe they made the antibody naturally. If you look a little further at 6 and 7, these people appear to have developed their antibody actually before the transfusion, huh? Look at this guy. He gets his transfusion on this day and that day. He got 2 transfusions. But his antibody actually turned positive 2 days before the transfusion. So it's a little hard to say the transfusion did such a good thing. The same is true with patient 7. He gets his transfusions here, but you'll notice his antibody test turned positive 1 day before the transfusion actually happened. And finally, the last patient, he got a transfusion and it failed. He didn't clear his virus, and in fact, he expired. He passed away. So at the detail, it's a little skeptical that the transfusions of plasma actually achieved anything during the Congolese outbreak. Nevertheless, people are interested in exploring this, but they have concerns. They're just listed here. If we start transmitting or transfusing plasma rather indiscriminately, we may do more harm than good. So while that is all happening in the background, people did have the sense that antibodies might be helpful, and the real effort, the high-tech effort, has been to engineer recombinant antibodies to make antibodies in vitro, which would attack the Ebola virus, coat the virus, and prevent it from infection. And there is one company in the United States which has made an antibody, the brand name is called ZMapp, which is a recombinant engineered antibody against Ebola. And this is just some data from the preclinical research in primates. And these are infected monkeys. The control, they're deliberately infected with Ebola. The control monkeys who got no treatment died quite promptly, whereas the animals who were given one of two versions of ZMapp, the animals given ZMapp 1 all survived. 6 out of 6 all survived. And so currently this product is being explored actively in human beings who have Ebola. What's interesting is that the prescribed dose that they used in these primates is an enormous dose. If you convert this animal dose to humans, you're giving 10 grams of a monoclonal antibody. That's an enormous quantity of antibody. Normally it's given in milligram doses. So this is a huge slug of antibody, and that creates a problem in production. This antibody, remember, is recombinant. It's not made in humans, it's synthesized. And the expression system that's used is a tobacco plant, if you can imagine that, huh? So they insert the DNA, which is coded to create the antibody. That DNA is put into the plant, and the plant makes a recombinant human antibody being made in a plant. It seems impossible, but it's true. And then you can harvest this tobacco leaf and extract the antibody. That's nice, but it's a very inefficient expression system. It doesn't make a lot of protein. And so it's very unlikely that this product, that in a very large scale outbreak, that there will be enough of this product around. And if you've been following the news on this, they quickly exhausted the supply with like 2 patients. So this is very interesting medically, but it may not be practical for dealing with an Ebola outbreak. But that's what you'll read about in ZMapp. I want to close now with some words about the future. And you can tell from the slide that I think the future is bright. I want you to have a positive feeling about the future, and that's the future in Africa, because that's an African tree. We don't have those where I come from. And I think the bright future that is ahead of us rests on 3 key features, right? 3 features, 3 keys to unlock the future. The first is technology. And I think we're clearly in a technology age. And there's a whole host of technologies that await us that we should be anxious to take advantage of. I've just picked one, just as an example. There is a fella in India who developed a way of using a smartphone, just like an Apple iPhone, and you put your finger over the camera portion of the phone and take a picture of your finger, and it will measure the hemoglobin that's in your finger. So this is a non-invasive way, no pricking, a non-invasive way to measure the hemoglobin concentration using a telephone. That would be a huge advantage in terms of deciding who needs a blood transfusion. You know, you could just determine this quite non-invasively. Now, I don't know if this is going to happen or not in real life, but I think we can look forward to a tremendous amount of new technology. A second key to the future is research. And as you listen these next 2 days, I want you to pay particular attention to some very important randomized clinical trials that you're going to hear about, which are being conducted in Africa. And I feel very strongly about this, that sub-Saharan Africa, healthcare in this part of the world, needs to do its own research to address its own problems. What's going on in the rest of the world is important, and you may want to take advantage of it, but the research being conducted in North America and Europe does not address your problems. You want to do your own research, particularly for your own needs. And so I highly encourage you, this is an academic part of the world, I highly encourage you to follow that path and do the research that you need to do to solve your own healthcare issues. This particular graphic just shows the hemoglobin molecule and how it kind of, the molecule itself kind of breathes as it takes up and delivers oxygen. And of course, the delivery of oxygen is essential in the world of blood transfusion. And so I just wanted to highlight one of the research projects that you'll be hearing about tomorrow from Dr. Debanji in pediatrics. And this is a research project, a very clever project on tissue oxygenation by blood transfusion being done here in Kampala at Malago. And he's measuring the oxygen delivery and the clearance of lactic acidosis and using this device to measure brain oxygen levels right here in Kampala, something that most parts of the world are not doing at all. So there's a lot of good research that is going on. You'll hear about it, and there's more research you need to do. The third and final key to the future is education. So I'm glad you're here. I think that the strong profession in transfusion medicine that we need to have for the future, given that population issue that you saw at the beginning, this future that we need to build depends upon education. That's the platform for the next generation of professionals in transfusion medicine. And I would say, looking at the audience, that maybe that future is beginning right now. So with that, I will thank you.